Brains in Motion with Mary McCone, Ed D, and Angela Zielinski, DPT. Please remember that this podcast is for entertainment purposes only. This is not medical advice, and this is just general discussion for educational purposes. Thank you. Enjoy. Hi, everyone. Welcome back, Mary, to our case study episode. We have a special guest today. Her name is Vlada Brudnik, and she is a brand new MNRI core specialist. Yay!
Thank you.
And she's going to join us for our special episode. We thought we would talk about a case study today. We learn a lot about reflex integration. We've all taken MNRI classes. We're all practitioners of reflex integration. And we thought we would have an episode where we kind of just talk shop about different ways that we would use reflex integration. And what's super fun is that I just went to newborn class for MNRI, and that's where I ran into Vlada. And I was telling her, she was like, "Oh, I heard you have a podcast." She was so positive, and I was like, "Yeah, Mary and I are going to do this case study. It's on toe walking." And Vlada goes, "Oh, let me tell you." And
Right.
The universe brought us together because Vlada is she's a chiropodist, which is like a podiatrist here in the States, and she has a lot of knowledge around feet. And she has personal experience with toe walking.
Mm-hmm.
So we thought we would bring her on for this. Mary, who is amazing and our linear thinker, created an outline. So this is not anybody specific. We just put like a general concept together so that we could talk about different things. And so, Mary, could you start us off with kind of our first couple things about our case study that we just created? Again, nobody specific, just a combination of different things that we see.
Sure, absolutely. So good to see you, Vlada. Welcome to the podcast.
Thank you. Thank you for having me.
Oh, you're very welcome. We're so excited. So for our case study, the first one that we created, this is a hypothetical 3-year-old who's been recently diagnosed with level 3 autism. They are minimally verbal. They can say, like mama and dada, they can point, but there's really no communicative speech. So a little bit of background for this case. Mom had hypertension during pregnancy, required an emergency C-section, and the baby went into distress. The child did not require any intervention after birth, so no NICU, no oxygen, and had a normal APGAR. After birth, the baby had some difficulty with latching and struggled with nursing. After several weeks of consulting a lactation consultant, the baby was switched to a bottle of pumped milk instead of nursing. And then we'll just talk about developmental milestones, then we can kind of work through that before we move on. So for developmental milestones, baby only rolled to the right, never to the left. They did not belly crawl, which in our world we call bower crawling. You might know it as commando crawling. They did not have a normal quadruped creep. So in the U.S., we call that crawling, where they're crawling on all fours. Quadruped just means 4 legs. Instead, they butt scooted, or when they did get on all fours, they would drag the left leg. The child walked at 10 months, but toe walks both barefoot and in shoes. Speech is significantly delayed. Like I said, they can say mama and dada, but does not have very much eye contact. So we have some more details that we can add, but I think that's a good place to start us off with. So who would like to start the discussion about our kiddo?
I'll take it. This is so 3-year-old and toe walking. That part is, so from a PT standpoint, how I would assess it, I would look at what the pattern looked like, because toe walking could mean lots of things. Are they bouncing when they walk? Do they sometimes come down on their heels? Is it only when they're excited? Is it all the time? And then I would see what other gross motor skills that they're doing as a 3-year-old. Like when they're running, what does it look like? Or do they come down does like sometimes if you toe walk, you can still have a running pattern that is typical, and sometimes you don't. So that's kind of how I would start, is just a more thorough assessment of how the 3-year-old was moving in space.
Mhm.
How about you guys?
So in my field, because I mostly practice MNRI now, but on a very part-time basis, I do my chiropody work. And for years, I've been getting parents with concerned kids who are toe walking and do the stretching and maybe stiff sole footwear, um, and then orthotics. That's what
Mm.
most parents want to see. They want some sort of intervention, some sort of device. But my mindset has shifted from that since I got into MNRI. So now I look at the whole body complex, the whole nervous system, and for me, honestly, I don't believe in the friendship between like constant walking or occasional.
Mm.
To me, as long as they're not properly grounded, I know there's difficulties already with posture, with, fight or flight, with the nervous system altogether. So to me, I kind of go to reflex in my mind to try to address that.
Mhm. And what reflexes would you immediately think of, Vlada?
Well, immediately trunk extension, that's for me a big one. And grounding and really Babinski and foot and guard and all the foot reflexes essentially. But generally speaking, like what I find definitely most commonly missing or like not properly integrated is the trunk extension in kids. Uh, I did when I was in chiropody school, I did a toe walking group project, and we looked at all the interventions and from conservative to invasive treatment. Like there's different tests when they determine the severity of the toe walking, especially for idiopathic toe walking, which something like 24% of kids have idiopathic toe walking. So for unknown causes, that's not related to ASD or any spinal issues or myopathies or neuropathies. And there's a few tests that they use, like a spin test. I don't know if you've heard, maybe you've done it in PT school, where you spin 10 times and then you ask the kid to walk normally and you see at what step, like to walk on a straight line, and then you see which step, like is it like right away they go on their tippy toes, or is it after 3 or 5 steps? And the sooner they start working on their on their toes is essentially like more severe. Um,
Interesting.
And then there's also the walk on your heels test. So
Mhm.
if they, which I'm sure, yes, that one you're familiar with.
Yeah.
So again, the more steps you can take without going on your toes, like on your heels, then that's, I guess, the better option. But again, if at some point, like you switch into it, like to me, that's already not the way it should be, even if it
Mhm.
happens sooner or a little bit later.
Yeah. Yeah. Mary, what reflexes do you think of with toe walking?
Well, I look at the whole pattern as well before I just look at the toe walking, and in the sensory processing piece, which we didn't mention, and that plays into my answer, so I'm gonna read that real quick. The child frequently engages in stimming activities.
Mhm.
There's various stims, including hand flapping when excited, finger flicking in front of his eyes, and mouthing objects. Sound sensitive, particularly to higher frequencies and lots of background noise, and will cover his ears and rock in response. Is sensory seeking for deep sensory input and bumps into things often. So when I look at a kiddo like this, I see that we have unintegrated feet reflexes, unintegrated rooting and sucking reflexes, and unintegrated grasp and probably Babkin palmamental reflexes. That is hands, mouth, and feet. So we have all the primary sensory reflexes that have unintegrated, and I look at those more as a collection because usually if one is active, there is another somewhere else that's active. They rarely come at a child this age and with this presentation. Usually, if the foot grasp or plantar reflex is active, you'll also see the palmar reflex or Robinson's hands grasp be active. Same thing with Babkin and rooting. Those two are really commonly tied. So I try to look at that as a whole. And for this kid, they've got a lot of those sensory reflexes that are still very unintegrated. So for toe walking, I think primarily of the plantar reflex, which is about understanding the front and back of your foot, right? Whereas Babinski is the sides, plantar's front and back. And trunk extension, TLR is a big one in toe walking, big one in toe walking. The test that Vlada, you mentioned about spinning, that's really a test of vestibular function, right? So when we're talking about a child being grounded, that plantar and Babinski and grounding and foot tendon guard, those are about understanding our relationship with gravity and where our body meets the ground and that feeling of stability. And kids are missing that. So when they're missing that understanding in their vestibular system, they come up on their toes to compensate from it. So like everything that everybody said all ties together. We just have a slightly different lens because of our backgrounds and our training. Yeah.
I think it's so interesting that both of you have mentioned proprioception and vestibular things like trunk extension, TLR, and then you mentioned the feet, but it's not your primary. Like neither of you, like it is in terms of like Mary, they are your sensory reflexes, but you're not just thinking feet because that's where the feet are. It's a very like from a piece where like all of us who have done the reflex integration training now know that even though it's toe walking and shows up at the feet, we don't necessarily start there or think that's the only issue, which when Vlada, I forget it because like orthotics are a big thing and sometimes they're useful, but I'm going to be honest, not the thing I think of for toe walking primarily.
Me, not so much anymore either.
So that's tell me if you would like, Vlada, would you like to share kind of like your personal experience with toe walking and kind of like your journey through like the typical path to your reflex integration path?
Do you mean my journey with my kids?
Yeah.
Yes.
Because if your daughter did, if and we don't have to, like if you're like, no, I don't want to, but you had mentioned that your daughter had toe walking and like that
Yes.
you kind of went through you went through this, like,
Yeah.
geez.
Very personal to me. So my daughter is my firstborn, and she was breech, born via C-section, skipped a lot of developmental milestones, and then just went on her tippy toes for cruising, and then on to walking, and I mean, and as we learn in school, up to the age of 3, it's all within normal ranges. Like kids will toe walk. By 3, they'll bring their heels down. They will eventually grow out of it, which is, our
I'm shaking my head because I have a lot of feelings about that statement of it being typical through.
Yes, we hear that a lot, especially in the pediatric world, right? They'll grow out of it. But yeah, so I mean, before I found MNRI, I just took it for what it was. I'm like, okay, she's doing her thing her way.
Yeah.
But then when my son was born and I stumbled upon an MRI specialist to address his torticollis, which was addressed within a few sessions because it was fairly early on. But then when the practitioner saw my daughter, they were like, oh, stuff is happening, is going on there. And so we started some treatments for her, and like things kept happening. Honestly, like I called it a modern day miracle.
That's so cool.
All the little pieces came together, all the stuff that I saw that I didn't really know how to, place or what to call it or anything. Yeah, that all kind of came together. So we started working with her, and her toe walking is better, but she still toe walks when she's excited and, emotions. But the interesting thing is when my son went through his developmental milestones and he hit pretty much every one of them, and then he started walking, and there was like no hint of toe walking whatsoever. In fact, it was a little bit more difficult for him to get up on his toes until about the age of 3. Even after 3, he started experimenting with that, like kind of like bring his toes up, like which to me, to see those two like extremes, even though one of them is probably more in the normal development scale versus the other, which is a bit more extreme. But to me, they were complete opposites. So it was really interesting to see.
Would you mind sharing what some of those other things were that you saw that you couldn't really figure out what they were? I think it might help our listeners if you're comfortable doing that.
Sure, yeah. Delayed speech, delayed potty training. There was a lot of holding on to objects and not like constantly holding things in her hands.
Can I ask a question just because you were
Yes.
the one that said, do you think that, and we're talking shop, right?
Yeah.
Do you think that was related to trunk extension of like holding, how like
Absolutely.
you can facilitate trunk extension by holding objects? That's one of like the tricks.
Yeah, I mean, I look at some of my videos of her looking back, and there was no trunk extension. I mean, like the whole posture was forward. It was like
Yes.
toes flexed, the whole like ready to fight or flight posture. So yeah, and when we started working, like doing MNRI sessions, then things slowly started happening. Like speech was coming in, like, you know, connection between like, you know, the enteric system and stuff. So it was very cool to see like the changes.
Awesome. That's so cool. Thank you for sharing. I know that it's when you have a personal connection to it, and I know
Yeah.
that like you've made so much progress with your kids, like it's incredible, right? Like
It is. To me, it's very incredible. Like MNRI was a life-changing, I don't know, experience for me. And that's why I basically kind of changed my career.
well, yeah. That's but you said you still once a week still
Yeah.
do the
My property stuff.
thank you.
Yes.
Yeah. And but because sometimes like, sometimes you do need support in like correct
Yes.
ways.
Yeah.
So I don't know. I'm digressing. But super
No,
cool.
and yeah, there's room for, I mean, to incorporate things like even orthotics are not like a complete no. Like you need to know like when to use them, for which cases and in what capacity, right? Because you could use them as a training tool, but not as like a restrictive bracing tool. Like you still want to allow for normal foot development. Yeah, I see it now as more of like a training tool.
Yeah, no, I wore braces on my feet when I was learning to walk, and then as an adult, I wore orthotics for years and years and had terrible foot pain. And Angela and I often share stories about our reflex integration journey. And I went to a class in another modality. It was an RMT class, and Moira said, no, this was at Carolyn Nyland in Colorado. She said, when you leave this class, you'll probably have to get new shoes. And I was like, yeah, sure. Because I used to always wear them out. I pronated pretty badly, and I'd wear them out in like 2 months. And after I left that class, I didn't need orthotics anymore. And I quit blowing through my shoes. Like it was so life-changing, and all the pain in my feet and everything just disappeared because I had such active foot reflexes. Yep.
Yeah.
When I work with a kiddo in person, one of the first things I have them do, if they're old enough, is walk down the hall so I can see what they're doing with their body. What are their feet doing?
Right.
What are their shoulders doing? What are their arms doing? Because for this little case study that we have, this little guy, like when he runs, he brings his arms up like little chicken wings, which we've all seen, right? Which is another sign of trunk extension, right? When they bring their arms up like this and they don't have that contralateral movement. So that's just another way that I look at kids kind of holistically with toe walking is what else do I see in their gait that would give me an indication. One of the things that I find with when people take their kids to various experts in the field, everybody wants to label each thing separately. Oh, well, that's toe walking, and you do this one thing for that thing, and apraxia is that thing, and you do that one thing for that thing. But in our work, we learn that everything is interconnected, and there isn't one thing that exists in isolation. It's related to something else. They're connected, right?
Absolutely. We have one thing that I would like to ask both of you, and when we put and we ask a lot in our histories for people, like, so this child is 3 years old, and we ask about crawling, and their crawling was they butt scooted or they were dragging their left leg. What is our reasoning behind asking that question as we're like doing our clinical reasoning? So like, Mary or Vlada, what do you guys think of when we ask that question?
Go ahead, Vlada.
Because we want to see that they had the right crawling patterns, which is going to be an early indication of how you're going to walk. So if you have the cross lateral movement, if you actually do develop your varese and your trunk extension and all those type of reflexes throughout the crawling. So it's and in my case, it was exactly that. Crawling led to proper walking, and no crawling led to that walking.
And so, like with most of the kids I work with did not bow or crawl. They did not belly crawl. It's like 95%. And Babinski is naturally integrated during bow or crawling, right? Because when for our listeners, when babies are crawling on their bellies, they actually push off with their big toe for propulsion, like to move forward. So when they skip that, they don't naturally integrate Babinski. And then that is one of the reflexes that may be involved in toe walking, although maybe not as common as plantar, but I often see them existing together because kids have a lack of stability, right? And sometimes they get mixed. You can do a test for Babinski and their foot will go into grasp, or you do a stroke for plantar and their foot turns sideways. You know, they do the Babinski where the big toes up, little toes down, and they turn a little bit to midline. Sometimes they get mixed up because the brain it's compensating, right? It's trying to find ways to keep them upright, because if you fall down, the cougar might eat you, right? It's about, I always use that kind of phrase, right? It's about keeping the human upright and in survival. So the brain will do what it needs to do. So that's one reason I look at that. And then the overall pattern of development for this kiddo, we know that they were emergency C-section. We know they still have proprioceptive deficits. So if we have proprioceptive deficits, and that's the foundation for cerebellar function, and which is where primitive reflexes, the action initiated for primitive reflexes of cerebellum. The cerebellum then feeds into the brainstem, pons, medulla, mesencephalon, which then feeds up the reticular activating system, which activates the, insula and the prefrontal cortex. I love to talk neuroanatomy, by the way. So
I love it.
Right. So tracing that development and looking at, okay, well, I see all of these patterns, right? We know that they have vestibular issues because they're toe walking. We know they have proprioceptive issues. We know they have auditory and visual. Their whole sensory system is offline. It's all underdeveloped. So in order to get to the toe walking, we really have to address it at that level. Like, we have to come from the bottom up. If I find in a lot of well-meaning practitioners who may not have done a ton of training, that they're doing a lot of top-down. Like you were talking about, we'll put them in orthotics or braces, but understanding how the brain develops, cerebellum, brainstem, diencephalon, neocortex, right? There is a particular pattern of development, and there's no skipping the line. There's no skipping the line on that. And if you spend the time doing the work at the bottom, which is why I spend so much time on hands, mouth, and feet at the beginning with everybody, a lot of neurotactile for proprioception, speeds the process up and it's more permanent and you get better neural connections in the brain. Right? That's my
Amazing.
philosophy.
No, those are both yes. Thank you.
I really like Mary's like outlook on it, because it's like I feel like I look at everything through a biomechanical lens, and I'm like, what are the biomechanical stuff? And yeah, you're looking at a higher brain stuff, because of your background, where it's, you know, learning difficulties and dyslexia. So it's very interesting to see it from that perspective as well.
Actually, a lot of that kind of understanding came from a functional neurologist that I've done some training under, and he's from the UK. It's really deep into neuroanatomy, and it really helped for me link what we do in reflexes to, oh, well, this kid's having an issue in the right side of the mesencephalon. Like, oh, and here's how we address that very specifically through reflex work. I am an analytical thinker, where I know, Angela, you watch and you observe and you like, we really have different approaches, but they both work. Just like I like to be able to explain to myself, we're doing this because this is what I'm trying to accomplish. I'm a teacher. I'm an objectives-based kind of person. What are the outcomes and how do I get there in kind of a linear sequence? I think it helps the parents I work with too understand kind of the path we're on and what the expectations are, what they'll see when we go through that process. A little bit more about our little case study. The last little piece here is that I think would be interesting in this is when he lays down on his back, his head is tilted back and his toes are pointed. So I'll let you mull on that for a moment. I wrote this case study, so when walking up or downstairs, he takes one step at a time and doesn't alternate feet. Cannot jump using both feet. I'll hold right there. What are your thoughts on that? As a practitioner, I want the listeners to be able to see this child through our lenses. I think that helps for parents to be like, oh, I'd never thought of it that way. So if you had a kid come in and or they sent you video or whatever, and you saw this kid laying, and when they laid down, their head was always up and their feet would flex, what would you think about that?
I think of TLR as well as lack of trunk extension too, of like, I don't know where upright is. I've seen a lot because I work with infants. I know, Vlada, you're working with more infants.
Yeah.
It's interesting how their concept of upright can be shifted just right, left, or like extension of center, depending on like how they came out or their birth story, or whether when you're doing head writing. And so sometimes it's like for me, I look at that a lot of like, can you find midline? And where's your midline actually at? And a lot of babies tend to kind of tilt that back because of that lack of trunk extension when they don't have like that TLR trunk extension foundation of pushing through their arms to go up, that concept of that gravity writing that comes from early on. And so I think of those kind of two reflexes in that posture. What about you, Vlada?
I think I would agree about the trunk extension, but I would probably think they're more in like that tendon guard system activated.
Ooh, yeah.
So like constantly having your toes kind of like, or your foot plantar flexed, or even the tilting back usually is accompanied by like the hunching over, and some of the techniques we do in the neurostructural modality is releasing the red green light.
Oh, I forget. Yeah, I was thinking upper ten. There's a upper tendon guard.
Yes,
is
that one. Yeah.
MNRI breaks down upper tendon guard, core tendon guard, and foot tendon guard as your tendon guard system that Vlad is talking about. That's a great point. Yeah.
Yeah, I would think that, but obviously that also comes with other stuff probably not being fully integrated.
Yeah, for me, I would immediately think TLR and extension
Mm-hmm.
because that, and then I also want to see, well, what are their arms doing? If their
Mm-hmm.
arms come up, uh, not out like Mora, but if their
Mm-hmm.
arms come up when they lay back,
Mm-hmm.
uh, and their head is back and their toes are pointed, I immediately TLR and
Mm-hmm.
extension, which doesn't mean that other things aren't present also, right? Because usually if TLR and extension stays active and they can't get into flexion, right? They're not going to crawl because they can't get into
Mm-hmm.
flexion.
Yeah.
But then they probably don't have integrated trunk extension, and they probably have core tendon guard and upper tendon guard active because those are to support you when you don't have the right things in place. So it's like, oh, well, I need to bring tendon guard on board to keep my human upright and alive, right? So that would be where I would immediately go, is look at that. And then um and if they're toe walking, so it doesn't matter if they're laying down or up, and they're still, because when they toe walk, usually there's
Mm-hmm.
also extension that goes with that as well.
Mm-hmm.
So it's just the way that I would view that.
It's so interesting. There's so many pieces in it, and there are so many pieces that are just not in isolation, right? Like it's not just one reflex. So toe walking is not just one thing. It is not just one reflex. In this first case study we mocked up a 3-year-old that has a diagnosis and clearly has some sensory processing difficulties, and you can clearly see the proprioceptive difficulties. What if we had a second case study of a similar 3-year-old, but let's say this 3-year-old doesn't have the diagnosis of anything. They're coming to you because they're toe walking. They are communicating verbally at an age appropriate level. Um, they're slightly behind on their gross motor skills because of the toe walking. They had similar birth stories where the mom had hypertension and there was an emergency C-section, but the child did not require any intervention after birth. What do you guys think about, would our treatment plan look any different for a child without a diagnosis?
So a lot of kids come to me with a plethora, a whole list of diagnoses, and it doesn't matter to me what the diagnosis is, because you could take a child to 10 different experts in different areas, speech pathologist, OT, neuro optometrist or behavioral optometrist, um, a reflex practitioner, like you could, a PT, you could take them to all these people, and every one of them is going to view that child through their lens and their training. And so you could get all these different diagnoses. Oh, they've got autism and SPD and OCD and PDA, from the psychologist. And to me, the question is, how are they presenting? Because the body tells the story. The body tells the story. You just have to see what the body is doing, and it will tell you what the story is. And the emotional regulation and the ability to attend and to maintain eye contact, all of those things tell you about what's going on neurologically. So I don't care what label it is. For me personally, it's what's the kid doing and how are they showing up in the world. Um, the differences that I see in this particular case, and then I'll let somebody else talk about it, is this kiddo, the family doesn't remember if this baby rolled both directions. They might have. They skipped belly crawling, but they did creep on all fours. They walked at a normal range. They have good communication, which is different than the first kiddo. And this kiddo likes to sit in color, whereas the first one didn't, but they have a hard time sitting still for longer than a few minutes at a time. So there are some differences in this kiddo. It seems like this kiddo has a lot better activity in the higher orders of the brain because we do have speech. There's better connectivity. So that would indicate to me that they probably have less reflexes that are still active, at least significantly. And it doesn't seem like the sensory processing is as deficit as the first case. So that's kind of my thinking. Again, I look at them holistically, so it's not just about the toe walking, but that is an indicator of what's going on. So what other information do I need to determine where I need to start with that kiddo? It's kind of my lens. Who else would like to take that one?
I agree with you that I don't necessarily care about the diagnosis. I kind of look at the presentation and I would treat accordingly. It's not like I would skip, certain reflexes if one kid was diagnosed versus not diagnosed. I would still, kind of try to hit them all. But I can give you guys an idea of what they would do if in the, PT podiatry world, if a child at 3 years old presented with toe walking and without a diagnosis, it would be considered idiopathic.
For our listeners, for clarification, idiopathic means without known cause.
Yes, thank you. First, they would say wait and see because they'll most likely grow out of it. And again, I guess depends on the parents. Secondly, they would suggest stretching. So again, stretching, which also most research shows that as soon as you stop stretching, then the toe walking goes back. Next, you would implement all those like stiff sole shoes and like carbon fiber plates in your shoes to like prevent the plantar flexion, and AFOs. And then the next kind of like in the severity of treatments would be serial casting, where they would actually like cast your foot every 1 to 2 weeks for up to 10 weeks or so. A lot of times that's also coupled with Botox injections into your calves to interrupt the nerve conduction into the muscle, so to relax the muscle essentially.
You're talking about what you would do from your training as a podiatrist, right? Or so I just want to clarify for our listeners that's not what you would do as a reflex practitioner, right?
No, that's
okay. Great, thanks.
That would be the general medical. If you go to an orthopedic surgeon or a podiatrist or anybody in the the medical system, that's how they would approach it, not how I would. And in Canada, our scope is a little bit different, so we're not allowed to do any bone surgeries. We can do just soft tissue things, but even getting into the Achilles would be a little bit of a gray area because we're technically ankle down.
This is why I appreciate Vlada so much, and like why this topic, when we connected at class, is because I forget what the typical model is and was. Oh, it's a good reminder, so thank you, Vlada, for like reminding us that outside the reflex world, this is how it could be approached. And instead, we approach it from like this holistic piece of reflex integration, and not just like Achilles based or like foot anatomy based, I guess would be the way to say it.
Which back then I thought like, yeah, this is a natural progression and that's the right thing to do. Just the way they taught us. But now that I found reflex work, it's just the missing piece. And to be able to offer, our patients, our clients, this other non-invasive conservative treatment, it's just, I can't even put it in words. It's a really powerful tool, I think, that I think we've all implemented in this point in our lives, right?
I had a parent bring her kiddo to me a few years ago, and the child was 6 and had been in AFOs like since they were 2, and all those years. And if they took them off, they just completely pronated. They would just collapse. And so I said, well, let's take them out so I can just see, how they walk. And then just poof. And I went, oh, okay. So we started working on these things. And I honestly, I've learned so much even in the last 3 years because I constantly take classes. It's kind of an addiction, honestly. I'll be truthful about that. I could probably make it happen faster now, but in that 6 months, she went from needing those to not needing them at all. And her ankles actually came right up, and in another 6 months, she'd learned to snowboard and skate, and, like, she just dropped them and never needed 'em, and I'm not a miracle worker, I just followed the development. Like, "Oh, okay, well, her brain doesn't know that she has a left and right side of her foot, and she's got a front and back side of her foot, and if we help educate the brain and bring trunk extension online and TLR online, she'll know where she is." We did foot tendon guard, we did all of those things that you mentioned earlier, and then she was walking normally, and we did a lot of balance beam work, to make her work it after we integrated it, and there she went. Mom sent me pictures of them on the ski slope, and it was just so lovely to see. So
Incredible. I love
yeah,
hearing stories like that.
yeah.
Yeah.
Well, that's why we do the work, right? You said something earlier too that I thought is worth touching on, regarding idiopathic, or in that oftentimes people are told, "Oh, well, your child has autism. Toe walking goes with autism." And so, like, somehow the autism is causing the toe walking. And for our listeners, I would just like to say that that is not a developmental view of autism at all. That from my perspective as a practitioner, autism is diagnosed on observational criteria, period. So at that time, the child is demonstrating deficits in these areas: speech, social communication, reciprocity, right? Across all the domains. And they have to qualify in so many areas to get that diagnosis. But it's not that autism causes other things. The diagnosis of autism is caused because of lack of connectivity, a lack of strong neural pathways, so that we don't have good sensory processing, and we don't have strong activity in the reticular activating system and the insula and the various areas of the brain and how they connect together. Well, what if we looked at it separately? What if we looked at, oh, well, they have an underdeveloped trunk extension and underdeveloped TLR and underdeveloped plantar and Babinski, and what's that causing is for the brain to perceive that it doesn't know where it is in space, and it doesn't know where the ground is, and it doesn't understand its relationship with gravity, and that makes the world unsafe, which means then that we're going to have a vagus nerve response, which means then that we're going to be more sensitive to sound and more sensitive to visual and less ability to attend, because our vagus nerve says danger, 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 run, run, run away, or go into protection, depending how severe the threat is. So I hope that our readers or our listeners can kind of wrap their heads around that when this idea of autonomic nerve um, activation and going into sympathetic, which is fight or flight, or protection, which is dorsal vagal, which we call moro or fear paralysis, can be triggered by these unintegrated reflexes that we're seeing manifest as toe walking.
We talked about 2 different 3-year-olds. And now I brought up, what if we had a 12-month-old? What if we had a 12-month-old who also doesn't have a diagnosis? They only roll to the left. They did bower crawl or belly crawl, but it's asymmetrical, and they prefer to butt scoot, or like the half knee in quadruped, where like they kind of propel with one knee. They do prefer to be standing, and they liked being in a jumper when they were coming up, and when they are in supported standing or getting ready to cruise, the child likes to go up on their toes to weight shift. So when they cruise laterally, they go up on their toes first, and then they move side to side, but they're not walking yet. The other thing that's of note is they don't like their hands to be touched. So when their parents try to help them with cruising, it can be a little challenging because they like to be up on their toes and they don't want their hands being touched. So how would our approaches be different or similar for a child that's a little bit younger?
Well, and the last sentence there, prefers to be holding an object and exploring with the mouth. And I think that's an important piece of information as well. Well, initially, what I saw, because same profile, same kind of birth history. So, you know, when it's an emergency C-section, I'm obviously thinking proprioception because to remind our readers, when babies come through the birth canal, they get all of that pressure from the birth canal, helps activate the proprioceptors for life outside the womb, helps partially integrate TLR as they're wiggling through. Helps activate the vestibular system for life outside the womb. So the baby missed all of that, as did our other two cases. Baby only rolled to the left. So what does that tell us? Probably 18R was only on one side. It didn't even activate on the other side, because you have to activate something before you can integrate it. If it's missing, which happened with both of my granddaughters, they were both emergency C-sections, and they both only had 18R on one side when they were quite little, so we turned it on the other side so they could roll to both sides. And because of that, because 18R was never active, of course they didn't have access to the other side of their body. So they can't do a proper Bower crawl. When they get to quadruped on all fours, they have to kind of drag one side because they don't have access to the other side, right? And then the part about doesn't like the hands being touched and likes to explore in the mouth. So we have Babkin, we have rooting, we have sucking, and we have Palmer. Oh, look, hands, mouth, and feet. We're back to that, right? And they have proprioceptive deficits because they like to have deep pressure. And we know if we have proprioceptive deficits, we're going to have vestibular deficits. Neurons are housed in the same part of the cerebellum, and they are dependent on each other. If you don't have good proprioception and vestibular communication, then the brain doesn't know how to move itself accurately to accomplish tasks, which is part of what we're seeing with this kiddo too. So even though this kiddo doesn't have an official diagnosis, there's a lot going on here that at 12 months of age, you can roll through it so quickly because they're still in their developmental window. We're not 7 years. Like when I get a 9-year-old, we're 8 years past that little window, and it takes a lot more work to get through that. But when they're 12 months of age, bing, 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 bing. Okay, that's what I have to say about that. Who's next?
Are we concerned about the jolly jumper or?
Yes.
So, in part of like the normal understanding, like the outside of reflex work understanding of the walking, they partially can say that for a variety of reasons. One of them is for unknown reasons, one of them is and one of them is learned behavior. So not necessarily that it's a learned behavior, but maybe the baby has been getting the wrong kind of sensory stimulation to begin with that didn't allow the reflex to fully integrate, right? Because remember, we have to go through like, is it 1,000 times of repetition or something for the reflex to fully integrate? So what if we haven't been giving them the right sensory stimulation for that, and that's what kind of anchored in their nervous system? So
yes,
personally, again, like my first kid, I did all that. I didn't know better, which probably didn't help. My second kid was just crawling, exploring, and yeah, I think a lot of those, developmental toys, they do good job marketing, but how did all of us, the generation before us, grow up without all that stuff, right?
And you don't know what you don't know, right? And there's when you said like the pattern piece, so what you're talking about is depending on the jumper or the placement is some kids bounce on their toes for the jumper because you don't know that there's like specifics for it. And there's also like they don't talk about in the marketing too about like ages and like where else are they in their development and things like that. So it can, like you say, create patterns that are hard to undo because they're in a supported system. So they think all upright walking is going to be supported. And so it's hard to retrain that into like a cruising anatomy.
That's just as an additional piece. Like, I agree that there is like things to work on, from birth, but that doesn't help.
No, and the same is true with the saucers, right? They're sitting and they're bouncing with their feet, and they're getting this input on the bottom of their feet that they're not ready for. So it's circumventing the process.
Yeah.
Again, it's like skipping the line, and they haven't gotten the awareness in the center of their body, right? Angela and I talked about this a couple of podcasts ago, that your cerebellum and your awareness of your body develop from the middle out, right? So the midline of our body, and then our limbs, and then our hands and feet. So when you're giving kids input on the bottom of their feet first, before they develop midline awareness and core development through trunk extension, TLR, Landau, 18R, all those, you're not allowing the natural development of the cerebellum and the awareness of body control. And then I thought the point you brought up about a learned pattern is actually really important, because even in trauma work, we've learned that our nervous systems are wired, right? Like if you experienced trauma in years 0 to 5, like domestic violence, abuse, and neglect, your nervous system is wired that the world is not safe and that being invisible is safer, right? So we know that this is true about our nervous system. It can be wired and patterned in a particular way. So if we give babies this kind of input and their nervous system learns that pattern, sometimes you do have to unlearn the nervous system. You have to repattern it, is a term that we use in our work, repatterning the system and the reflex.
Yeah. And usually with infants, that's a good segue, or with littles, you're trying to pattern so that they're set up and just using it. And repatterning is good for older children. But if they've already got a learned pattern, or if half of their body wasn't available to them because ATNR hadn't turned on and they're already compensating, there's a little bit of repatterning with patterning, which is why working with infants and a little bit younger, why I brought it up, is a little bit more technical or a little bit more specialized. You have to be careful, because when you said it's very easy when you're younger, the reason it's easier is because if you pattern and open up the correct pathway, they're in this developmental window where they're just moving and they're now using the reflexes because that's what they're supposed to be doing. Whereas when you're older, you're not rolling, you're not crawling, you're sitting in a chair, you've got different expectations. So it takes longer to repattern because you're not doing those same motor patterns within the same windows. And we want the nervous system and the child to be the one to integrate it, not the practitioner. So you as the practitioner don't want to be integrating reflexes for a child, which is like at 12 months old, you're in a pretty safe window. But when you get younger and younger, it's things that we just think about as we're looking at all these pieces and as we're trying to set up treatment plans.
Can I ask you clarification on that, Angela? When you say the practitioner doesn't want to be the one integrating the reflexes, do you mean for this younger group?
For the younger group, yes. Of like,
okay, thank you.
Of if I passively, like if I do, say for example, leg cross flexion extension, if I keep doing it over and over and over again to where the body never uses it actively, if I'm just doing it passively, they don't know how to functionally use it. And so you want babies to functionally use that. And with older kids, the level of doing that is you have a bigger window. Like you can't over integrate older kids because they've already done the pattern, but infants haven't used the pattern yet so you have to kind of walk this line of, if there's like certain repetitions and certain things, whereas infants it's less repetitions and more about, is the pattern on correctly so that they're using it is what
Well, because the patterns are encoded in our DNA. So if something got interrupted that pattern from activating, once we activate it in an infant, that genetic encoding will take over most of the time, unless there was something like a stroke or some big event in utero, which is pathological development, and that we're not really addressing that today. That would be a great case study for another time. But we're talking about a kiddo who just had, they were C-section, right? I mean, that's like 30% of the births in the US, so that's not unusual. So why is this kiddo having trouble? Well, 18R is used to help get through the birth canal. Maybe that's why it didn't activate, because they didn't have that experience. Sometimes we just don't know, right? But if we can activate that DNA encoded pattern in these little tiny ones, but like before 12 months of age, then oftentimes, Angela, I believe the term you have used when you've consulted with me on some of these little cases is that babies are just going to work it out, right?
Mm-hmm.
So we'll kind of add some, we'll do a little work and then let them work it out. And then we'll do a little work and then we'll let them work it out. And babies will work it out if they have the right pattern. So like, I was just looking for that little piece of information. Thanks so much. Yep.
Yeah, that's the hope.
That's the hope.
We just want to say thank you to Vlada for joining us today on our case study. Thank you for your time, your expertise, and we want to remind everyone that reflex integration is just a link and a piece to different treatment plans, and that we value other practitioners. And today was just talking about different approaches and how we can all work together and how we look at different pieces to help our clients be more comfortable in their bodies and to help our clients thrive. Thank you again to Vlada. You can find Vlada at Feeling Well Place in Toronto, Canada. They have a Facebook page at facebook.com/feelingwellplace. If you liked this case study, please let us know. Like and subscribe. If there is a hypothetical case that you'd like us to talk about, please contact us. You can email us at brainsinmotionpodcast@gmail.com. You can find Mary at her website, brain-works.org, or on Facebook with her Facebook Reflex Integration groups. If you would like that information, please check our show notes. And you can find Angela at angelapt.com or rainbowdragonbooks.com. Thanks for listening.